from the study before the 12-month period.
As a summary, Doctor, what did the authors of this study find with regards to quality of life measures?
They found that some of the subdomains for physical functioning and mental health were statistically significant. They were better from a statistical point, which is to say it was not due to chance alone at the end of the study.
Well, we'll put a pin in that for a second. We'll come back to it, those three studies. But you were talking about the monitoring of abuse, misuse, and diversion concerning Janssen products, specifically Duragesic. Did Janssen continue to monitor data on Duragesic after it was marketed through studies such as this and others?
Yes, sir. Every one of these studies, every clinical trial we would have done, at each of the time points in which the physician saw a patient, they would have been asking for how is the patient tolerating the drug, is the patient experiencing any adverse events, and he or she would be recording any reported adverse events on the case record form, which would ultimately be entered into our database.
If I say risk management plan, does that have special meaning to you as a medical affairs person?
Yes, sir, it does.
Can you tell the court what risk management plan means to you?
Yes, sir. We're moving away from the clinical trials now.
Moving away from the, we're going to get back to those. I
Okay.
promise, Drew, I won't break my promise.
Okay. The FDA recognized that for certain compounds, which included the opioids, there were specific risks associated with the opioids, specific risks that had poor outcomes, such as risks of respiratory depression, death, abuse, misuse, and diversion. And so for some of those compounds, including Duragesic, the FDA requested a risk management plan where the company would specifically assess those risks and come up with interventions or ways to manage those risks and report the results of the identification and the management of those risks over time.
In your capacity as a medical affairs person with Janssen, were you involved in the creation of that risk management plan for Duragesic?
Yes, medical affairs was.
When was that plan drafted?
I believe it was drafted in 2004. It was in the mid-2000s.
Even before that, did Janssen have a plan for following risks with Duragesic?
Yes, we had the surveillance plans in place even before there was an FDA-mandated risk management plan.
Earlier in your testimony, Doctor, we discussed the PDRC, Prescription Drug Research Center. Do you remember that?
Yes, that was the Pinney Group.
And were those PDRC reports, which are in evidence, another example of Janssen's efforts to monitor its drugs while they were on the market?
Yes, sir, it was.
In addition to working with Penny and PDRC, do you recall Janssen working with Dr. Ted Cicero?
Yes, sir.
Tell the court who Dr. Ted Cicero is and how you work with them.
Dr. Ted Cicero is a recognized expert in the field of abuse, misuse, diversion of opioids. And Dr. Ted Cicero was an individual we worked with even before Duragesic. He headed up an independent steering committee that we had in place to monitor tramadol in the late 90s.
What is the independent steering committee?
When the FDA approved tramadol, Ultram, the FDA made a determination that they would approve the drug without scheduling it. This would be a non-scheduled opioid. In the medical review, they determined that there would be an advantage for access to tramadol without scheduling it, but of course there was a concern around abuse, misuse, and diversion. Ted Cicero's group put together a surveillance program that monitored for tramadol abuse, misuse, and diversion after the drug was brought to market and as a non-scheduled opioid to determine whether there were going to be actual concerns with, we knew that there would be some abuse, misuse, and diversion, but whether the level of these activities would rise to the point where we needed to schedule the drug, or understanding the risks, the drug could remain as an unscheduled opioid.
And the independent steering committee, I think you told me, was 1994.
It came soon after the drug was approved, yes, sir.
Did something happen with that committee in 2006?
Well, it was an official group. I mean, it was a group that made reports regularly to us.
And did it ultimately go into the radar system?
Yes, sir.
Which the court will hear about more later, but let me just hand you J960. And ask if you can identify this one.
Yes, this was a report to Pricara on the assessment of the abuse of Ultram ER. This is the extended release formulation of tramadol and fentanyl products. And let me also say that just going back to the mid-90s, the Independent Steering Committee was really the very first of the type of surveillance activities that were conducted around an opioid product on the market at the time. And it formed the basis for many of the surveillance programs that were subsequently instituted for all other opioids.
And this J960 has a date on it. When does it indicate that the review was conducted?
The review was conducted over data collected between January 1st, 2006 and August 2nd, 2006, and the report was made August 1st, 2006.
We'd offer J960 into evidence.
No objection.
J960 will be admitted into the evidence.
And how did these authors report they conducted surveillance to assess abuse and diversion of Duragesic?
Yes, sir. I'm sorry?
I said, how did the authors go about doing their work?
Oh, I'm sorry.
That's quite all right.
Yes. They used a variety of surveillance activities, again, in some ways similar to what we had previously heard for Duragesic, where using different tools, they were able to assess across the United States what was happening with respect to abuse, misuse, and diversion of these products.
And did they have a section of the report that dealt with diversion of fentanyl?
Yes, sir.
If you'll go to page 15 of the 32-page report, I believe you'll find that section. What did the authors discover about diversion of fentanyl as reported in J960?
They found 1,675 diversion cases during the first quarter of 2006, where fentanyl was mentioned in 35 of those cases, or a total of 2.1% overall. Of these 35 fentanyl mentions, these were all fentanyl, including Duragesic. Of the 35, 16 were for the Duragesic patch, 12 for the generic patch, 2 for Actique, which was a buccal formulation to put in the mouth for fentanyl, and 5 for Sublimase.
If you go right above that highlighted section on diversion cases, what did they conclude about diversion of fentanyl?
I'm sorry, where are you?
Right above the 1,675 cases there.
Okay. That the diversion of fentanyl is relatively low.
Did they also track abuse?
Yes, sir, they did.
And if you could go to page 13, is there a section there called fentanyl abuse?
Yes, sir.
And can you tell the court what the authors reported as to the rates of abuse of fentanyl?
Well, in just reading parts of it, despite widespread claims and assertions by the FDA and DEA, fentanyl abuse rates are very low, and almost all of the reported abuse involving the fentanyl patch formulation, not the injectable or oral lozenge. The latter is interesting since there has been considerable discussion by DEA and media that narco-pop abuse has become endemic.
And do they also find that abuse, what do they find with regards to abuse there at the bottom of the section?
You're talking about the second paragraph now?
Wherever you want to go, I was looking at fentanyl in any of, but you're free to
Yes.
read whatever part you want.
Yes, the low rate of abuse of fentanyl was puzzling, and hence in a study funded by an unrestricted research educational grant from Prescriber, we studied nearly 800 subjects about their drug preference, including fentanyl, in terms of drugs identified by prescription drug abusers as their primary drug. Hydrocodone and oxycodone products were by far the most frequently mentioned. Fentanyl in any of its formulations was selected by very few subjects as their primary drug, only 13 of 793 subjects. By way of explanation, our subjects reported that fentanyl is too unpredictable and dangerous to use, and hence is seldom the drug of choice.
Now, you mentioned Prescriber. What is Prescriber?
At the time, Prescriber was the sales and marketing group that was Janssen.
And if we notice right below there on Roman numeral 2, did
Yes.
this group also follow tramadol?
Yes, sir.
The federal government scheduled tramadol when?
I believe the federal government scheduled tramadol in 2014 or 2012. It was after I left the company.
And some states soon.
Yes, sir.
Did Janssen have a role in providing information to states when it learned they were considering scheduling tramadol?
Yes, sir.
How so?
If we were aware that a state was considering whether to schedule tramadol, we asked that we be given the opportunity to provide the information that was collected through these various surveillance activities to the group that was making those considerations.
I'd like to ask you about an email that is in evidence, S0463. Can you put that up, Terrence? Recognize that?
Yes, I do.
All right. What is it about?
Well, if we start from the beginning of the trail of emails, Dr. Vorsanger.
Dr. Vorsanger being someone you mentioned earlier.
Yes, do you have a copy so it's a little bit clearer to me?
Of course.
Thank you.
And I just want to know in general, I'm going to call your attention to some of the items in the email.
Yes, sir. As I said, when we learned that there was activity in a state where they were considering whether to schedule tramadol, we had access to the only data from the surveillance program. So we knew through the level of the surveillance we did what was happening on a nationwide basis and why we would see small spikes in the abuse, misuse, and diversion of tramadol. And in some instances, we would only learn of the potential activity of the pharmacy board that the meeting was going to be in the next day or a couple of days, and we would try to pull together a team that could quickly engage the group and provide the data that we had access to, the only data on surveillance that we had access to. This often involved sending Dr. Ted Cicero and Dr. Gary Vorsanger to present these data. It became a bit onerous to try to manage to do that on a 1 or 2 day notice.
Now, I take it you all don't get a vote in whether tramadol is scheduled or not scheduled. That's done by others.
That's correct. Our purpose in providing the data was exactly that, providing the data that we had collected from a source that would not be available to the group making those decisions.
And did you respond to Dr. Vorsanger?
Yes, I did.
What did you tell him?
I told him that I understood the concerns of trying to pull together a team with very little advance notice and pulling together the data. And I, in essence, said that, yes, let's see if we can pull together a team. I termed it a SWAT team, which I put in quotation marks because it was a metaphor for a team that we can quickly mobilize to provide this information.
I want to ask you about, may I approach the board, Your Honor?
Yes, you may.
I want to ask you about the word here. No, no, I'm not going to touch your board.
Just not what
That word right there, read it for the court.
Yes, mobilize as soon as a threat is detected.
Okay. When you said threat in that email, what did you mean?
From the surveillance information that we had collected, we knew that we knew several things, and also in speaking with our physicians. For one thing, our physicians were very concerned about having tramadol as a scheduled product. They expressed to us the concern that with tramadol moving from a non-scheduled to a scheduled product, that physicians would simply write for more potent opioids. That once you've scheduled it, why wouldn't I write for a hydrocodone or an oxycodone product? And so there was the potential that patients would be receiving a more potent opioid when tramadol might be the most appropriate choice for them if they had access to it. Conversely, we knew from the surveillance program that many of the blips we saw where we saw that tramadol was a drug of abuse or misuse were fairly short-term and often in areas where access to other drugs of abuse such as heroin was not available, and so they would use tramadol short-term. The threat then was to patient access if the drug were now a scheduled product and not a non-scheduled product. Some of those patients would be put on a more potent opioid.
And what information would you share when you would share information as reflected in this email?
The kind of surveillance data that we were collecting on where we were seeing the abuse, misuse, and diversion of tramadol, for what period of time we were seeing it. Usually it was through one quarter and it dissipated by the following quarter through the various surveillance mechanisms we had in place.
Okay. Do you have any more you need to say about that, Doctor?
No, except that, again, speaking with physicians, we understood what the FDA had said in their review of tramadol, that there is a value to having a non-scheduled opioid, and to the extent that we could present the data that we were the only ones that had access to from our surveillance program, and then so that the board that was making that decision had as the best available data to them on making that decision. That was the purpose in providing, in going down and providing those data.
Okay, sorry to go down that rabbit hole, but I figured we should cover that. We were talking about the Duragesic risk management plan when we were diverted by that part about tramadol. Did you present the Duragesic risk management plan that we've already noted to the FDA for approval?
Yes, sir.
And when was that done?
I believe it was 2004.
Did the FDA approve that program?
Yes, sir.
I know you're going to, may I?
Yes. You got good workers' comp.
I've just handed you, Doctor, what is a binder of the Duragesic Risk Management Plan and Progress Reports. As you can tell, there's an index there, correct?
Yes, sir.
This is Exhibit J 446 we'd offer into evidence.
No objection, Your Honor.
J 446 will be admitted into the evidence.
Now, don't worry, Dr. Moskovitz, we're not going to go through the whole thing page by page.
Thank you for
But I
that.
would like you to look at page 2, and Janice, if you can call up page 2. Maybe, maybe not. We'll do it the old-fashioned way then. Everybody follow along. What is page 2? What is on page 2 that is important to you, if anything?
This is the index to the Duragesic risk management plans, and it shows that the risk management plan was submitted to the FDA throughout the period of 2005 through June of 2012.
And can you tell from looking at this Duragesic risk management plan what it contains? Is there a table of contents or anything that would allow the court to see what's in it?
It included the risk management plan and any of the progress reports, any of the findings from any of the aspects of the surveillance program that were put into place.
We may get into some of this a little later on after the court's had an opportunity to read the entire plan at the next break. Can you just give us some idea of what's in that big binder in front of you?
Yes, based upon all the surveillance, and this included the surveillance that was the routine surveillance we did, such as adverse event reports, a review of the literature, and all of the active surveillance we did from key informant networks, from recognized databases such as Dawn, from laboratory testing, a variety of means by which we assessed, risks of abuse, misuse, and diversion. Consistently, we found that Duragesic had low rates of abuse, misuse, and diversion, and in particular compared with other opioids, particularly long-acting opioids, it was among the lowest.
Doctor, to save us from having to go through the report in its entirety, did you prepare a presentation about this risk management plan while you were at Janssen?
Yes, I did.
And did you do so in your capacity as the Medical Affairs Pain Group Director for the therapeutic area?
Yes, sir.
You may.
I've handed you what has been marked J412. Is that what you were just describing to the court as your presentation about the risk management plan?
Yes, sir, it is.
You will see and take a breath of relief that it is much thinner than the actual plan. We've moved J412 into evidence.
No objection.
J 412 will be admitted into the evidence.
And again, using this front sheet, can you tell the court what it is?
Yes, this was a presentation I made internally to senior management and other groups within Janssen to explain why there are risk management plans in effect and the purpose of these risk management plans. For one thing, it required us to subscribe to certain databases and to provide funds to do the surveillance.
Just like I don't want to go through the whole plan, I don't want to go through the whole slide deck. It's all in evidence for people to look at if they wish. But I would like to refer you to page 19 of that deck and ask if this is a summary of the risk management strategy that you included in your program.
Yes, sir, it is.
What are you trying to illustrate with this slide?
So to summarize, a risk management strategy is in place because the FDA has identified special risks associated with a compound. And by identifying those risks, we can assess where those risks are occurring, in what population those risks are occurring, how those risks are occurring, and by assessing them through a variety of methods, whether they be additional studies or specific studies on abuse, in vitro non-clinical studies, we can manage those risks through a variety of means. And those would include changes to our labeling, educational programs for the healthcare community, our launch and promotion items, ongoing surveillance, as we just spoke about, and that ongoing surveillance would include both the routine surveillance, such as adverse event reporting and literature reviews, and the active surveillance programs that we spoke about, such as the key informant network, the feet on the ground, where we understood what was going on at the community level, also the distribution and supply chain and manufacturing. And this was an iterative process, so as we learn of new risks, there are other interventions we may choose to take.
I noticed that under all the things you just talked about, there's a box that says management over them all. What
Yes.
do you mean by management?
Well, once we've assessed the risks and understand where the risks are coming from, we can manage those risks through one or more of the boxes down below, whether that in terms of changing or different versions of something that was going on below.
We talked about product labeling earlier. How do product labels fit into all this effort to manage risk, if they do?
They most certainly do. The product label is going to outline the indications, how to select the patient properly, what are the contraindications, the warnings, the precautions, how to select the proper dose for the patient, how to monitor the patient over time, how to change dose if necessary, how do you educate the patient, what's the patient information that you need to be sharing, and then there was a separate document that went, as part of the labeling, that went to patients as well, so they understood the risks of the medications.
Skipping over some of this, Doctor, you were mentioning patient monitoring. Tell the judge what you mean by that.
Part of the education on assessing the patient and monitoring the patient long term, there was in the medical literature there was the concept of assessing the 4 A's at each interaction with the patient, and that would include analgesia, what was the pain relief that the patient was getting, adverse events, was the patient tolerating the drug. We knew that there were common adverse events, constipation, nausea, vomiting. Some could be treated, some would dissipate over time. Activities of daily living, this was some functionality measurement. This is difficult because you can't expect that every patient who's going to be getting your drug is going to be running a marathon. This is something that would be individualized between the physician and his or her patient. For a young individual with chronic pain, it might mean that they can return to work. For an older individual with a great deal of osteoarthritis or low back pain, it might mean that a functional measurement might be, can I get you out to do your shopping? Can I get you to enjoy the time you spend with your grandchildren? So that was the third A, activities of daily living, and abuse-related behaviors. You needed to determine with your patient what was happening. Are there behaviors that I need to be concerned about that would suggest you're not using the drug exactly as prescribed, and why?
We previously, doctor, referred to a timeline of various product labels.
Yes, sir.
And as I recall, the second one up there was 1994.
Yes, sir.
Is this the label, these labels, is the kind of label you're referring to when you say patient monitoring is discussed?
Yes, sir.
And if we were to pull up J27, J412. Can you pull it up, Janice? Excuse me, just a second. There you go. So, if we look at one of these patient labels, it will discuss patient monitoring. We were talking about what that contained.
Yes, sir.
Been there, done that. Let me get to it the final way. You mentioned 4As. What are those, please?
The analgesia, pain relief, adverse events, activities of daily living, and abuse-related behaviors.
Okay. And are these the kinds of things that are discussed in patient monitoring in the label?
Yes, sir.
All right. Now, if we go to this again, the risk management strategy, the second box, Dr. Moskowitz, you just walked us through one of the boxes about minimizing risk and labeling. What is the second box?
Education.
And can you tell the court how Janssen would attempt to minimize risk through education?
Yes, to the extent that we would provide information on proper overall selection of patients, and here too we would be instructing about the 4 A's, risks of abuse, misuse, and diversion, proper background information about pain management, the best practices of pain management, and these might include additional journal articles, websites. That was the type of education that we provided.
Okay. Now,
It would also include funding for continuing medical education programs.
the fourth box, which is surveillance. Can you tell the court, we've talked a little bit about that, but what is routine, passive, and active surveillance under that box?
Yes, the routine surveillance was the type of surveillance that we would be conducting with respect to adverse drug reports that would be coming to us on a global basis from clinical trials that would be done, from our review of the literature, It would also be in concert with our receiving the FDA's adverse event system. Sometimes a patient or a physician might report an adverse event to the FDA and not to us, or vice versa. So we would have both databases available to us to assess for frequency and severity of adverse events, to detect if there is a change in frequency, a new adverse event, or a change in severity of a known adverse event. So that was the routine. That we also, as I said, monitored the literature to determine what was the safety profile just from the overall literature review.
And are you familiar, Doctor, with the different programs that were used for routine passive surveillance?
Yes, primarily we're talking about internally the Scepter, the internal safety database that we maintained, and the FDA's adverse event reporting system, the AIR system.
Is that discussed in the slide program that you have got in front of you?
I believe so.
Can you go to page 33 of that program and tell me if that's what you have in mind?
Yes, sir.
Can you explain to the court what this tells us about the passive surveillance in place that you have been discussing?
Yes. If you recall, when we spoke about risks, there are risks associated with any drug, but specific to the opioids, there were risks of special interest that the FDA designated, and these would be risks of abuse, overdose, misuse, and diversion, and a number of other adverse events of interest. And the various databases and information we collected was able to address the knowledge base for all of these identified risks.
Okay, you
The
got
first
three?
two being the FDA, the Janssen safety database. You'll sometimes see the term Scepter here because that was the name of the database.
I'm sorry, again for...
I'm sorry, Scepter is SCEPTRE.
Thank you.
Yeah.
Now, next,
And the FDA's adverse event database, which was the AIRS/SRS database.
okay, and then there's something next to it, TESS. You know what that is?
Yes, treatment. You'd have to remind me of what the acronym is. I'm sorry, I don't recall all of the initials. This was the Poison Control Center.
Yes, we'll get you the acronym.
Okay.
NFLIS.
National Forensic Laboratory. And again, I need the...
National Forensic Laboratory, first three get you
Yes,
a prize.
yes.
IMS.
This was a database that allowed us to look at prescriptions, sales of Duragesic. So it provided for other issues, the ability to look at rates, because this was relative to either the number of patients who received the drug or the number of prescriptions that were out there.
TESS, Toxic Exposure
Exposure.
Surveillance System.
Thank you.
You're welcome. You should thank Nessa. She's the one that knows. And then last, the court has already heard about DAWN. Can
Yes.
you remind us about that?
Yes, the Drug Abuse Warning Network. This was, these were cases of, in emergency rooms across the United States, of emergency room visits where there was a isolated drug where which was associated with a case of abuse overdose, and reported into the DAWN database.
And when you have a check in the box in your presentation there, what are you trying to say?
That in some cases we had multiple systems that were able to track a particular risk. And I think, yes, in all the cases we had more than one database that was able to track it, but across all of the systems we were able to track all these risks of identified risks for the opioids.
Now, as I understand it, the NFL, which you got the first three of, is the National Forensic Laboratory Information System. That ring a bell?
It does now, yes.
Okay. And what is that following? What data does it collect?
They're looking at seizures of diverted drug, and they're testing for what was the drug that was being diverted.
Okay. Who keeps DAWN data?
SAMHSA, there's a government agency that manages the DAWN data.
Is that also true of the National Forensic Laboratory?
I believe so. I'd have to verify that.
Toxic information?
That was the Poison Control Center.
The FDA, clearly a federal agency.
Correct.
Now, this is passive surveillance, correct?
Well, this is both, it's passive surveillance in the sense that we're getting the data. That's correct. These are not the feet on the street type of surveillance. Yes.
Is there also a component that you noted on the original slide we were looking at labeled active surveillance?
Yes, sir.
And can we go to page 34 now? You've got another slide, active surveillance.
Yes.
And can you tell the judge what active surveillance is being done?
This is the radars reports that were coming in, which included such things as the key informant network. There was a law enforcement.
I don't think you need to stretch your
Okay.
memory here, because if we go to the next page, there'll be
We'll have
something
it.
about...
Well, so it was the radars program. It was also media monitoring. So we were continuing to look at media reports of abuse, misuse, diversion, and we also put in place internet monitoring so we can see what was going on at the level of some of the chat rooms.
something you had told the court about earlier this morning.
Yes, sir.
If we can pull out page 35 of this exhibit, there's your radars.
Yes, sir.
And I told you we weren't going to stretch your memory. Can you tell the court what radars consists of?
Yes, there were these four networks, which was a key informant network. There were individuals throughout the country who filled out a survey on a periodic basis reporting what they became aware of with respect to abuse, misuse, and diversion in their 3-digit zip code area. The law enforcement network, this was reports from law enforcement departments throughout the country on seizures of medication, American Association for Treatment of Opioid Dependence. I believe these were admissions to methadone clinics, and the Poison Control Network. These were calls about an individual who has concerns because either he, she, or a friend abused, misused, diverted a drug.
Do you remember when radars began?
I believe radars began in 2001. It was the early 2000s.
And there's already been mentioned that it was a system that was started by Purdue Pharma
Yes.
in this trial. Does Purdue still own it?
No, it does not.
When did Purdue give up its role in radars?
I believe it became an independent agency the mid-2000s, I think 2005.
Okay, 2005, 2006. And
Yes, sir.
And there's been testimony in this case that it is operated by the Denver Health and Hospital Authority. Does that ring a bell with you?
Yes, sir. That's the independent group that maintains the radars databases.
When did Janssen begin subscribing to radars?
Right around the time that it became an independent agency.
2006?
Yes, sir.
And after Janssen subscribed, did it begin to receive information going back to 2002 when the program began?
Yes, sir, we did.
And did Janssen receive reports from radars summarizing data for every particular quarter data was collected.
Yes, sir.
If we could bring up Your Honor,
Yes.
I'm trying to bury you in a pile of paper, Dr. Moskowitz.
Which is why I'm placing it on that ledge instead of in front of me.
Can you tell us what 17, 18 in front of you is?
Yes, this would be the radar's report of annual data in 2014.
Is it an example of the kind of information you would receive from radar?
Yes, sir.
This one involves what particular substance?
Uh,
Or is
in-
it restricted by substance?
This is specific to tapentadol. This was Nucynta.
And I believe this is one of the documents that was introduced this morning, Your Honor, 1718, just for purposes of the record.
Thank you.
Now, we've already mentioned that this is a copy of a radar's report from 2014. Is this the same kind of radar's report you are familiar with?
Yes, sir, it is.
This is a radar's report that discusses tapentadol.
Yes, sir.
And tapentadol, for my memory and the memory of the court reporter, is the active ingredient in which of Janssen's drugs?
In both Nucynta and Nucynta ER. So it's both the immediate release and extended release formulations of tapentadol.
And did Janssen also receive information about other drugs that it had other than tapentadol?
Yes, sir. We received information from the various surveillance activities on other opioids as well.
Does radars collect data at the national level?
Yes, sir, they do.
Are the networks listed? Sorry, we go back to the prior one, Janice. You mentioned the networks that are involved with radars,
Yes, sir.
and I believe that was on J412.
Yes.
I'm not building numbers.
It's
Thank you.
So I don't need. Yes, I don't. This is included in this. Okay, thank you.
Now, what I'm trying to do with the help of a few of my good friends is to discuss these four systems that you have summarized in the slide deck that we discussed earlier.
Yes, sir.
And starting with the key informant network. Can you
Well,
put,
let me say, for purposes of the 2014 data, radars had expanded some of what they offered in terms of surveillance. So you will see programs that came into being later on and which don't appear on my slide. So as an example, there was the college survey program. So it goes beyond what was in place early on for the Durgiza program.
okay, what we have up here, though, is one that was on your slide, right?
Yes, sir.
Okay. And it's got a big number 1 on it, so let's start with it. What is the Key Informant Network?
The Key Informant Network this is specifically one of the outgrowths of the program that was put in place by the Independent Steering Committee with Tramadol. The Key Informant Network had patients in numerous private addiction treatment facilities, and they would complete questionnaires in which they would provide information on their primary drug of abuse, where they got that drug, how much drug they used in the month prior to treatment, and the roots of that abuse.
You mentioned just before we began talking about that, the college survey program. I believe that is discussed in an exhibit already admitted, J1718. Anything else that you need to tell us about the Key Informant Network as part of the RADAR's surveillance program?
No, sir.
I believe you have a number 2 in front of you there?
Yes, sir.
What is the law enforcement network, and what is it comprised of?
This would be information on diversion of various opioids in the geographical area of interest. This would be reporting that would come from law enforcement, medical boards, pharmacy boards, departments of health, and state prosecutors, and specific to diversion.
Okay. Again, one that is discussed on your slide there.
Yes, sir.
All right. Janice, can you put up, if there's one, number 3? This is one I remember you talking about because I remember the acronym, AATOD. What is that, doctor?
This is patients who were admitted to opioid treatment programs would complete a survey that would then be collated to collect the data. And the questionnaire, the survey that they were completing would include information about demographics and where the geographical location of where they resided. Again, information on opioid drug use over the past month, over the lifetime, and at what age they may have begun to use the opioid. Their primary drug of abuse, the preferred drug, the source from which they obtained that drug, drug craving or drug withdrawal symptoms, and their pain status.
Anything else on this slide you need to tell Judge Bachman about?
No, sir.
I think there's a number 4, Dennis. Can we go to that? This is one you've mentioned before, the Poison Control Center
Yes, sir.
network. Can you tell the judge what that is?
These were calls into poison control centers where the call was because there was a intentional or unintentional drug exposure, and they would be calling in to report unforeseen, unplanned events, adverse reaction. These are the side effects. In some cases, it was an intentional intake of a drug for suicide, or intentionally misusing a drug, or abusing a drug, using the drug for the euphoric effects, or withdrawal of that drug. And there were standardized fields in which the Poison Control Center collected data on patient demographics, the characteristics of the exposure to that drug, what product was involved, what route of administration it was given, and the outcome of that exposure.
And is this information that was used by Janssen to follow Duragesic and any other product that it was following with the radar system?
Yes, sir.
Did the system also give you information about fentanyl abuse?
Yes.
We previously discussed the college survey system. Let's get to it. I think it is number 5, the one that you mentioned was perhaps not in the original slide deck.
That's correct. This was added by the Radars group later on.
Okay. Tell us what the college survey program keeps track of.
They would enroll college students to complete a questionnaire several times a year. The survey was conducted across all regions of the United States, where approximately 2,000 surveys were conducted for each of the 3 times over the course of a year, and it was used to estimate scope of prescription drug use among students, what was the route of administration, and where did they receive the drug.
Again, I believe for purposes of the court, this is all referenced in J1718, and Amy, you'll check and make sure that's in evidence. Okay. It is in evidence. Good. Thank you very much. Now, if we can go back to J412, page 35, which is the slide we started from.
Okay.
And we got them all there, the details of them, including the last one, the college survey program, correct?
Correct. That was new, added later after when I presented these data.
Now, in addition to radars, which you had just gone through, did Janssen also conduct additional internet monitoring as part of its surveillance?
Yes, sir, we did.
And was that done internally or by Janssen, an outside party that Janssen hired?
That was done through an outside party.
Do you know who that outside party was?
I believe at one point it was Inflection.
Do you also monitor media?
Yes, we do.
And how do you do that?
For mentions of our products and other products to determine, again, why drugs are preferred, the routes of administration, changes in the trends over time, frequency with which the various drugs are mentioned.
Who within Janssen reviews the findings contained in this Duragesic risk management plan, if they are in fact reviewed?
Yes, they are. There's a team that reviews these data. We called it the risk management team.
And is there an external review committee at Janssen?
Yes, sir.
Tell the court what that is.
Yes, sir. These data were reviewed internally by the risk management team. These were individuals within medical affairs, the R&D organization, regulatory, legal. It would be shared with senior management for all of those groups, but then we would also share the information with an external review committee, a group of individuals who were independent of Janssen and could review the data independently and make recommendations to the changes that we might consider making to assess and manage these risks.
And is that external review committee contained on page 30 of your slide there?
I'm sorry, what page?
30.
Yes, sir.
Can you kind of go through with the court what the external review committee does and who is on it?
Yes. Let's start with who. The external review committee was composed of individuals with expertise in pain management and addiction management, individuals who had an expertise in law enforcement, including supply chain, experts in regulatory issues. This might include an ex-DEA individual, an epidemiologist who would help us in assessing trends over time, and we also thought it was important to include a medical ethicist on this committee to address ethical issues.
And does this slide generally describe the external review committee and its function?
Yes, they would be reviewing the top-level data of all of the radars and internal adverse event reports that we received and reviewed, that we had reviewed and made recommendations to senior management on.
Is Janssen required by any federal agency or governmental entity to have such a committee?
No, sir.
Why did it?
because we thought it was the right thing to do. We didn't want an echo chamber where we were simply assessing these data without having an outside set of eyes on it and advising us whether our conclusions, whether they concluded what we concluded or whether they were seeing the data in a different way.
Did you compensate people for serving as members of this committee?
Yes, sir, we compensated them for their time.
How often did the committee meet?
In most instances, they met twice a year.
And did they meet for an hour, 2 hours, a day, a week, what?
No, in general, we would meet over the course of a day.
Now, does your slide deck also discuss how well this system works? And if you can look at page 44.
Sorry?
Page 44.
Thank you. Yes, this is an example of some of the information we learned of through the surveillance programs. Do you want me to continue?
Why'd you put that in your slide deck? The slide deck was created how many years ago?
2006.
And why'd you put it in the deck? What is it supposed to show us?
Well, we wouldn't have known this without having the surveillance programs in place. We learned that there were individuals dying of fentanyl back in 2006. And we wanted to know, was this fentanyl coming from Duragesic, coming from our pharmaceutical product? And so we learned of this through our media monitoring in the poison control centers, where they picked up the signal that there were these individuals who were dying of exposure to fentanyl. Ultimately, we dispatched a DEA agent, a former DEA agent, to investigate at the geographic site what was going on. And at the time, we learned that the fentanyl that was causing these deaths was not from pharmaceutical Duragesic, but was coming from a clandestine laboratory in Mexico.
Is this all you need to share with the court from your slide deck, Doctor? Do you have anything else that we need to discuss?
Only that we know from such cases as this that fentanyl is a drug of abuse. It's sought, but to the extent that we followed up with Duragesic through labeling and through surveillance program, we managed the risks and working with the FDA through the risk management plan.
Thank you for hanging in there with me a while. Doctor, we're getting ready to shift subjects. Judge, if you want to take the afternoon break, or I'll keep going.
Let's keep going.
Okay? Let's discuss radar's data. You spoke earlier about the surveillance system called radars. Let's talk about some of the data from that system. Did Janssen receive reports summarizing radar's findings on fentanyl abuse and misuse?
Yes, sir, and data on abuse of other opioids as well.
Okay, and did Janssen at some point stop receiving radar's reports directly?
Yes, sir.
And we'll talk about this later, but generally, why was that?
At some point, I believe it was around 2012 to 2014, the FDA put in place a class-wide REMS program, a Risk Evaluation Mitigation Strategy program, whereby the REMS data were provided directly to the Food and Drug Administration.
Doctor, did you help us pull together?
The radar's data. I'm sorry if I said REMS. It's the radar's data.
You're allowed to correct yourself. You've been there a while, you're going to make a mistake or two.
And if I find it, I'll correct it.
Did you help us pull together some graphics that discussed the radar's data that Janssen received?
Yes, sir, I did.
And let us start with
Yes, sir.
Demonstrative to mark is the next barring objection. Oh, sorry.
Thank you.
Doctor, I didn't mean to. Is that what we were just discussing?
The radars program, this was a specific aspect of the radars program, yes.
And if we've got that marked as a demonstrative, may I publish it, Your Honor?
Yes.
Can you tell the court what Janice will put up on the board here in just a second? What are we looking at?
This is one aspect of the radar's data. This is coming from the key informant network. Again, these were individuals throughout the country who would fill out a surveillance on what was happening in their communities with respect to abuse, misuse, diversion of various opioids. And here you're seeing a geographic map of the areas that were completing these surveys and reporting them into radars.
Right there in the middle circled is the state of Oklahoma. Are there key informants in the state of Oklahoma?
Yes, sir, there were.
So data from Oklahoma is included in this?
Data from Oklahoma were included in the radars network.
Does this information break out fentanyl specifically?
Yes, it does.
And I think the second document you have there is a graph.
Yes, sir.
And it says data consistently shows low rates of use for fentanyl. Is this the fentanyl data from the information that you were just telling the court about?
Yes, sir.
Now, I'm terrible at graphs, plus I'm colorblind. So can you help us with this graph and tell the court what it shows?
Yes, sir. Well, let me start off by saying that the information you're seeing over here is not Duragesic-specific data. These are data for fentanyl in all its formulations. So whatever you're seeing, the piece of it that would be Duragesic would be even somewhat less than what you're seeing for overall mentions of fentanyl. Let's talk about the two different graphs. There are various ways in which you can look at issues of abuse. And here are two primary ways which are consistently reported.
Just to help me, doctor, because I am colorblind, is fentanyl a color on that chart?
Yes, perhaps if I approached, I could, yes.
Can you point your finger at it so
Yes.
I'll know what line you're talking about?
So fentanyl is this lime green, and what we're seeing is the lone here, and the same would be true for the other graph.
Okay, thank you. I'm sorry to get you up. I just wanted to be able to follow along there. Go ahead and tell us what you're reading in this graph and what's important about it to you, if anything.
Okay, if you don't mind, let's go back to where we had the graphs side by side, just so I can explain.
Of course, and if you need to get up, I'll ask Judge Botman's permission and we'll see if he'll let you. But
I think we're fine, but it's important to understand the two different graphs we're seeing over here. The first graph is simply reporting the number of mentions over a population in that area. The population, the number of mentions per 100,000 population, whether or not they were taking, whether they had a prescription for any of these drugs or were taking any of these drugs. It's a measure of what's out there in the community, regardless of whether there were prescriptions or not. So it's a rate per 100,000 population. In the second graph, to a degree, we're normalizing this because clearly, if the drug had very few prescriptions, you would expect to see fewer total mentions, and vice versa. If there were a lot of prescriptions, you would expect to see more mentions. So it's normalized by the number of prescriptions. Here we're talking about the rates per 1,000 unique recipients of dispensed drug. So these are,
Is that what URDD stands for?
yes, sir, unique recipients of dispensed drug. So these are individuals who got a prescription for the compound.
And what do you learn when you compare the lines on these graphs either to the graph itself or compare the two graphs together?
There are differences depending upon the compound, and it's interesting to note some of what we're seeing. Again, if you will, may I approach the...
Yes, you may.
In the first case, we're seeing oxycodone and hydrocodone as being the two top lines on the graph. There are a lot of mentions per 100,000 population over time. Conversely, we're seeing very few for oxymorphone. This is this black line that's coming in over here around 2011 when it was brought to the market. That's why you're seeing this graph begin over here. But if we normalize this to unique recipients of dispensed drug, the drug was let's start with oxymorphone. The drug was introduced to the marketplace at this time. There were really very few prescriptions, and yet it was a drug that, relative to the number of prescriptions, you saw a lot of mentions. It was a drug with a significantly more higher rates of abuse relative to the relatively small number of prescriptions. Conversely, when we look at oxycodone and hydrocodone, these are the hydrocodone, these are the Vicodins, these are the Lortabs, these are among the most widely used opioids for any reason, and most of them, these are short-acting and long-acting. The hydrocodones, the Vicodins are the short-acting, the oxycodone are the Percocets, the Percodans, and OxyContin. And there are many, many prescriptions written for these. You're seeing the high level of mentions, but when you normalize that for hydrocodone, which is the red line, by far and away the largest number of prescriptions in the United States for opioids and for oxycodone, per the number of prescriptions written, you're seeing those numbers come down.
What does this chart or either of them tell us about the abuse of fentanyl in the time covered, 2008 to 2014?
That relative to all of the opioids available, whether we're looking at the rates per population, simply the numbers that are out in the community, or rates relative to the number of prescriptions, the levels of abuse of fentanyl reported through the key informant network are relatively stable and lower than most of the other compounds.
Is there anything else, Dr. Moskovitz, on these charts or the other map that we used with them that you feel it's important for Judge Botman to know?
Yes, over this period of time, we're also tracking tapentadol. Tapentadol here is only available as the branded Nucynta, and you will see that tapentadol is on the population chart, the lowest line, and among the lowest for the rates per unique recipients of dispensed drug. In fact, one of the things you'll see is when tapentadol is introduced to the market, compare that with oxymorphone, which as soon as it was introduced to the market was considered, was abused much more frequently relative to the number of prescriptions as a new drug entry into the marketplace. Tapentadol, as a new drug entry into the marketplace, started off with low rates of abuse, and they remained low over this period of time.
Thank you, Doctor. We also discussed the law enforcement network, as I recall.
Yes, sir.
And
Yes, ma'am.
may I approach, Your Honor?
Yes, you may.
Thank you.
Yes.
So you're adopted.
Thank you.
And we'd ask that these be marked as court exhibits next. Can you tell Judge Bachman what we're looking at with this map?
Yes, sir. These are the reports in from the various law enforcement agencies that made reports to the law enforcement network of radars about rates of seizure of the various drugs over, this is 2014.
Now, I'm going to assume that the part over there next to Florida that says dark box reporting and light box not reporting, is that what I'm seeing?
Yes, these are the areas from which the radar system got reports.
Again, Oklahoma is circled.
Yes, sir.
Is Oklahoma a reporting state?
Yes, it is.
Now, there is a chart or graphs, just like we had before, on the second page of this court exhibit. And the date is 2002 through 2014.
Yes, sir.
What, if anything, do these charts tell you?
Well, again, we have two charts, one which simply reports the number of seizures over the total population, just the number of mentions, and the second is normalized based upon the number of unique recipients of the dispensed drug. And here, too, we're seeing that rates for fentanyl, which are, again, the lime green, or tapentadol, which is the grass green, if you will, remain low throughout this period. And under the unique recipients of dispensed drug, fentanyl remains low throughout this period. Tapentadol, it kind of looks like there was one blip just as soon as it was released onto the market, and then it remains among the one or two lowest lines that we're seeing.
Can you, with the court's permission, again show me which two lines we're looking at in case I think of a question to ask you about them?
Yes, sir.
Is that all right?
Yes.
Here we're looking at the lime green, so here is the fentanyl line. Thank you. Here is the fentanyl line, and here is the tapentadol line, which barely moves from the baseline per 100,000 population. It begins over here with the launch of tapentadol. And when we look at the unique recipients over time, we're seeing fentanyl, again, among the lowest of the lines, and tapentadol, there's a blip here. This may be because we only had 2 prescriptions, so the denominator would have given us this spurious increase, but very soon thereafter, this was the lowest line through that period.
As I understand it, Doctor, from your testimony, we're talking about diversion now.
Yes, sir.
And what do these charts, if anything, tell you about the levels of diversion of tapentadol and fentanyl as compared to the other substances on it?
That relative to other opioids, the rates of diversion, whether you're talking about population-based or based upon unique recipients of dispensed drug, were generally lower than other opioids more commonly used.
Anything else, Doctor, that you need to tell Judge Bachman about these two charts?
No, sir.
You discussed the opioid treatment program.
Yes, sir.
Portion of radars, that was the acronym I liked, I can't remember.
AOTODD.
Right, may I?
Yes.
We'd ask these be marked as court's exhibit next, and Doctor, can you tell the court what it is looking at here?
That there were opioid treatment programs These are individuals who are coming into opioid treatment programs where they're completing a survey relative to the drugs of abuse over the last year or month and where they got them from. And here you're seeing the areas that are reporting into the RADAR's network.
Again, Oklahoma is circled. Is Oklahoma a reporting state to this portion of the RADAR's program?
Yes, sir, it is.
And like the other court exhibits we've looked at, there is a group of charts too on the second page of that court exhibit. Can you please tell Judge Botman what it is you think is important about these charts, if anything?
Again, we're seeing that regardless of whether we're talking about rates per population or rates normalized by the number of unique recipients of the drug, a measure of the prescriptions, the overall rates for fentanyl and particularly tapentadol are among the lowest.
Of course, you're going to tell me they're the same greenish colors I can't see.
Yes, the same lime green and grass green.
Could I have him point those out so
Sure.
in case I need to ask some other question about them?
On the first chart, we're seeing fentanyl down here and tapentadol coming into the marketplace in 2009, barely rising among the axis.
Okay, now this is the population on the one over 100,000 people.
That's correct.
And the next one we're going to see is the unique.
Recipients of dispensed drug. This is normalized for the number of prescriptions, and we're seeing the rates of fentanyl over here, and for tapentadol down here.
You previously told us that fentanyl doesn't break out as to Duragesic or other fentanyl products. Is that true on these charts as well?
That's correct.
And what does this information tell you about the rate of abuse for fentanyl as compared to other substances listed there?
The rates consistent with what we've seen in some of the other graphs was lower than most of the other opioid products. And it was particularly so for tapentadol.
Anything else, Dr. Moskovitz, that you need to alert the court to in these two charts?
No, sir.
Let's keep going.
Keep going.
Yeah.
Yes, sir. May I approach?
Yes, you may.
We'd ask these be marked as court's exhibit next. Can you please tell Judge Botman and Tanya, whose fingers are quickly being worn to the nub, what we are looking at?
This is that fourth aspect of the RADAR's network, the poison control network.
And is Oklahoma a reporting state for that network?
Yes, it is.
I'm going to bet that there are some graphs attached to the back of this exhibit. Would I be right?
Yes, sir.
Can you please take a look at those graphs and tell us what they are?
Again, we're seeing two graphs, one reporting rates, mentions per population, and the other showing a normalized graph where the rate is normalized based upon the number of prescriptions that we're seeing. And in both, we're seeing that with respect to misuse reported to the Poison Control Center, tapentadol and per 100,000, tapentadol and fentanyl are among the opioids with the lowest mentions. Again, we're still talking about the same lime green and grass green.
I'm going to take it they're somewhere around the bottom.
They are somewhere around the bottom, yes.
I'm not going to make you get up again, but if you need to point something out, I'll ask the judge for permission for you to do so.
That's okay. And you're seeing the same for rates normalized per unique recipients of dispensed drug, where you can see where tapentadol Nucynta comes to market in 2009.
Going back to the previous chart, what are the two lines separating, no, the chart, the 100,000 population over time, what are the two lines there at the top that are above the others?
Simply mentions per 100,000. These are oxycodone and hydrocodone. Again, oxycodone being such things as OxyContin, Percocet, Percodan. There's short-acting oxycodone that's available as well. Hydrocodone, these are the Lortabs, the Vicodins, and the most widely prescribed opioids.
Anything else that you need to alert Judge Bachman to on these charts?
No, sir.
May I approach your Honor?
Yes, you may.
Ask that these be marked as court exhibit next. Can you please tell the court and counsel what we're looking at here?
This is that additional program that was introduced later on, the college survey program. These are the surveys that college students across the United States complete to report on drugs of abuse on the college campuses.
Again, is Oklahoma a reporting state?
Yes, sir, it is.
And the college survey program is the one we've referenced before that is not on the slide deck you presented, but is in the exhibit that I mentioned for the record previously.
Yes, sir.
There are two charts. College survey program abuse rates 2008 through 2014. Can you please tell the court what, if any, significance these have to you?
May I approach? Well, we are thankfully still seeing the same colors that were carried throughout.
Or not seeing them in my case?
As we saw with the previous slides, the drugs with the most frequent mentions are hydrocodone and oxycodone, and then you're seeing tapentadol down here, and fentanyl with the lines across here. There's a number of the compounds are very close in terms of the number of mentions overall, but the largest mentions are for the two opioids that are most commonly prescribed. And here we're seeing the rates normalized per 100,000 unique recipients, per 1,000 unique recipients of dispensed drug over time. When you normalize it, again, you're seeing that despite the fact that in the previous slide, the population slide, oxycodone and hydrocodone were at the top of the slide, when you normalize that by simply the large number of prescriptions that are written for these compounds, you're seeing them to be among the lowest. The oxymorphone, which comes to the market over here, very few prescriptions, but the largest number of mentions. And you're seeing the other lines. Again, as we saw in one previous slide, you're seeing this spike with tapentadol shortly after it's introduced to market, where there are very few prescriptions. So any mention is going to show us a spike over here. And we're seeing pretty much all of the other compounds in a relatively small band.
We have now looked at charts from the Key Informant Network, Law Enforcement Network, Opioid Treatment Program, Poison Control Network and College Survey Program, all as described by you in the surveillance tool that is RADARS, are you able to draw any conclusions from these as a group?
Only that when we reviewed the data, we consistently saw that the products that Janssen marketed, Duragesic, Nucynta, and Nucynta extended release, were consistently among, if not the lowest of the products that were mentioned, regardless of whether we were looking at this through the population-based or unique recipients, with the exception that there are clearly spikes early on when a new drug is brought to market, but those dropped off very quickly.
Thank you, Doctor. Again, I'm getting ready to shift subjects. Do you want me to move on, Your Honor?
Now would be a great time to break. Let's go ahead. Let's go ahead and take a 20-minute break. So we'll begin again at 3:20.
Thank you, Your Honor.
have a seat. You may resume.
I was afraid you were going to say that. You ready?
Yes, sir.
Dr. Moskowitz, you have gone through now a lot of graphs, charts, and explanation covering the RADARS program. Do you know whether Janssen submitted to the FDA periodic reports just as the ones you've summarized now?
Yes, sir.
And are these referred to as periodic safety update reports, which the court will remember in his long list of PSURs that were admitted earlier today?
Yes, this was exactly the kind of information that the FDA required of us on a periodic basis.
Are they submitted on a regular basis?
Yes, sir.
And is that every quarter?
Yes, it is.
They can be lengthy submissions, can they not?
They certainly can.
In fact, contained in J2672 are the PSUR reports from May of 08 to April of 09, which have now been admitted into evidence, and there are, I believe, 13,000 pages in the thumb drive that the court has at its bench. But we're not going to go through them all right now. Rather, we're going to switch gears and move to the REMS program. Can you remind the court and counsel what REMS is?
Yes, the acronym Risk Evaluation and Mitigation Strategies is the FDA was given the authority to require a REMS program for drugs where there were specific risks that they identified. And the REMS program was put in place to maintain that benefit to risk ratio. The FDA recognized that there were drugs, not just opioids, but drugs that had significant benefits for selected populations, but certain very high risks. And so by implementing a REMS program, they could maintain the benefits while minimizing the risks.
Did the FDA itself develop the REMS program?
No, sir.
How was the REMS program developed?
With guidance from the FDA on the elements that would be required for REMS, the company would put together a proposed REMS program and submit that to the FDA for the FDA's review.
Was it just one company or a number of companies that contributed to the REMS?
Well, if you're speaking of tapentadol, that was a REMS program initially that was developed specifically by Janssen for tapentadol. If you're talking now about the class-wide REMS for opioid products, that was a REMS program that the FDA asked the manufacturers initially of extended release products to develop as a class-wide program.
And did Janssen respond to the FDA's request to develop REMS for tapentadol?
Yes, sir.
Do you remember when that was done?
That was when we submitted, it would have been before the approval of the extended release formulation.
And did Janssen and other companies respond to the FDA's request to establish a REMS for long-acting opioids?
Yes, sir. I remember that period very well.
And when was the class-wide REMS approved?
Well, in 2007, the FDA convened a meeting of all manufacturers of extended release opioid products and told us that we had to develop a class-wide REMS. That continued through certainly the period that I left Janssen. I believe the class-wide REMS was approved in 2000. The initial class-wide REMS was approved in 2012.
All right, and during the time that the class-wide REMS was being developed, did Janssen continue with the the REMS as it related to tapentadol and its risk management plan for Duragesic?
Yes, sir, we did.
Did the FDA ultimately approve the REMS plan for tapentadol or the class-wide REMS program for long-acting opioids?
Both. Initially, they approved the REMS, the tapentadol ER specific REMS program before the approval of tapentadol ER. Subsequently, tapentadol ER was part of the class-wide REMS for the extended release opioid products.
Is this a regulated program?
Yes, sir, it is.
Can you explain to Judge Bachman in what way it is regulated?
The FDA, there's legislation that outlines what the FDA can require for a REMS program. There are elements depending upon the drug for which they're asking for a REMS program.
Would you characterize the REMS program as a product of industry?
No, sir. We have to follow the FDA guidelines on putting together the REMS program, and the REMS program ultimately will be submitted to the Food and Drug Administration, but can't be implemented until they've approved it.
All right. Now, you are familiar with the REMS program,
Yes, sir.
and that is contained in J2148, which I believe has been admitted. And if we can pull that up, Janice, page 11. Does that look familiar to you?
Yes, sir, it does.
Okay, can you tell the court what we're looking at?
We're looking at the extended release long-acting opioid, thank you, risk evaluation and mitigation strategy, supporting document that was prepared by the REMS program companies, which include all the manufacturers of extended release and long-acting opioid analgesics listed here.
And can you pull up page 11, Janice? Can you tell us what we're looking at here? Starting there at the bottom of the page.
Okay. These are some of the elements that go into the REMS program. They are the patient counseling document on extended release long-acting opioid analgesics, an FDA blueprint for prescriber education. In essence, it's what has to be contained in any materials that are provided as education around these products. A prescriber letter 1, 2, and 3, or letters that went to professional organizations that they in turn would provide to their members, and a website from which individuals could access the REMS program.
Now, the court has already heard a fair bit about the REMS program, but I'd like to turn to page 20, if you could, Ms. Conway, which I believe is the table of contents for the REMS program. Have you seen this before?
Yes, sir.
And can you tell the court what we're looking at on page 20 in these tables, this particular one being table 1?
On the left side, we're seeing the specific piece of the REMS requirement and an explanation of that in the right-hand side. So on the left, as an example, we're seeing evaluation of a patient's understanding of the serious risks associated with these products. This would be done through a patient survey to determine what their level of understanding of these materials is, whether they received the medication guide that every patient would need to receive with each and every prescription that's filled at the pharmacy, and how often we would be submitting this information, this survey information, to the Food and Drug Administration.
What is number 5 there?
The surveillance, monitoring for misuse, abuse, overdose, addiction, death, and any intervention to be taken resulting from these signals. And you're looking here at the elements that we've spoken of previously, the elements that we spoke about in the RADARS program.
Is there mention of DAWN in this document?
Yes, the first, the emergency department visits for opioid overdose and poisoning events. That would be the DAWN data.
Radars is mentioned,
Yes, sir.
NaviPro.
Yes, sir.
Anything else that the court needs to know is included in this REMS program that he might not have seen earlier in the testimony?
Only that some of the inflection programs we put in place before the requirement for REMS, and they included such things as internet monitoring. The individuals would look to see how these drugs are described on internet sites that in some cases are specific to a population that might abuse the drug, and what drugs were of interest and how they would abuse it.
May I approach your own?
Yes, you may.
Let me hand you Dr. Mr. Marco's J3600 company report and ask if you can tell Judge Bachman what this is.
This is the initial REMS approval, showing the initial REMS approval of 07-2012 with a modification in 06-2015 of the REMS program.
We'd offer J3600 in that.
No objection.
J3600 will be admitted into the evidence.
Doctor, if I can point you to page 9. And again, you are free to stop at any page that you think would be good. This page is labeled FDA Blueprint for Prescriber Education.
Yes.
Actually, can you tell us what we're looking at there?
Yes. As part of the REMS program, the FDA mandates that we provide education to the healthcare provider, not just for his or her use in making decisions about what's an appropriate patient and how to treat the patient and how to monitor the patient appropriately, but also the information that the healthcare provider would need to counsel their patients on the risks and benefits of the extended release opioids.
And under REMS, do all companies which market extended release or long-acting opioids have to provide education to physicians about the medications through CME courses?
Yes, this is the blueprint. The blueprint is in essence saying these are the elements that you need to cover in the educational program you're putting together for the healthcare providers. You need to cover this, and this, and you need to cover what information you're going to be sharing with the patients so he or she understands the risks associated with these compounds.
Doctor, have you taken this course?
Yes, I have.
Why did you take it?
I maintain my license in New Jersey. As part of my licensure, I have to complete continuing medical education courses. In New Jersey, one of the required courses for the CME, in addition to the regular CME, it was required that I complete a course that was the REMS program for long-acting opioids.
You're required to do that to keep your New Jersey license?
Yes, sir.
Do you know whether Oklahoma requires its doctors to complete the REM program?
I don't know.
Now we'd like to change gears a bit and talk about some of the issues that came up earlier in this case. I'd like to talk to you about something that came up earlier in the questioning at the very beginning of the case, what I'll call the Duragesic warning letter. Do you know what I'm talking about?
Yes, sir, I do.
While you were working at Medical Affairs, do you recall Janssen receiving this letter as it related to a Duragesic file card?
Yes, sir, I do.
What is a warning letter?
Well, specific in this case, this is a letter that the FDA would send the company indicating that they found a promotional piece to be not in accordance with the regulations around what is permissible to be used in promotional advertising of a drug.
Do you need a copy of that letter? It's in evidence for the court's purpose. It's 0038.
Thank you.
Just in case we ask questions about it, Dr. Moskowitz, I'll hand it to you so we'll have it.
Thank you.
Have you told me what a warning letter is now, based upon your understanding?
Yes, sir.
And you told me that it can take issue with promotional materials.
Yes, sir.
Did you receive a copy of this letter while working in medical affairs?
The regulatory group did, but it was shared with the groups within Janssen. Yes, sir.
Yes, who's the letter addressed to, I guess I should say?
Well, the letter was addressed to Dr. Ajit Shetty, who at the time was the CEO of Janssen Pharmaceutica.
And you recognize the document in front of you as being that letter?
Yes, sir, I do.
Now, as I recall, and you're free to refer to the letter, and if I'm misstating it, I'm going to try to get through it pretty quickly. The FDA took issue with 3 studies cited in the file card, right?
3 studies and the use of the Dawn data.
And the 3 studies that we're talking about are Simpson, Milligan, and Allen that I discussed earlier today, correct?
Yes, sir, that's correct.
At a high level, just give the court some idea of what the FDA's issue with these studies was.
The FDA found that the claims that we were making in the promotional materials were not supported by the studies, the 3 studies that you just cited.
And were the promotional materials submitted to the FDA?
Yes, they were.
And the court's already heard about Form 2253 and how all that's submitted. That's your understanding of how those promotional materials are submitted to the FDA?
That's correct, sir.
All right. So we have Simpson, Milligan, and Allen, which you have discussed earlier. In your testimony, did the FDA say these were bad studies?
No, sir, they did not.
Did the FDA say these studies were incorrect in their conclusions?
No, sir.
Did the FDA say these studies shouldn't be made available to the medical community or withdraw them from their peer-reviewed journal where they were published?
No, sir, and through our medical services group, we make these publications available in response to unsolicited requests.
Did this file card go through Janssen's promotional review committee that the court heard about earlier in both your testimony and this case?
Yes, sir.
Do you think, what did the PRC or promotional review committee consider about these studies and decide about them?
That they supported the statements that were made in the promotional piece.
And do you believe those studies were improperly cited in the file card?
I do not, but I understand the FDA's concerns.
Okay, and let's just talk about that. As we relate to the Simpson study, which was in front of you but is probably buried in this sack of material here in front of me now, do you remember what the FDA's concern was?
Well, need to look again specifically at the Simpson study, but for some of these studies, they indicated that these open label studies did not provide sufficient rigorous support for efficacy.
Go ahead and pull it up. Can you pull it up? Simpson, yeah. We're getting this for you on the screen, Doctor, so you won't have to test your memory.
Thank you. Thank you. Yes, specific to Simpson, this was a study in chronic low back pain, and the file card specifically mentioned chronic low back pain, and the FDA indicated that the drug was approved for chronic pain and not specifically, we couldn't call out chronic low back pain.
And in fact, if you look at page 2 of the letter you received from the FDA, it discusses Simpson, and what does it say? It's on page 2.
The file card states on page 4, demonstrated effectiveness in chronic low back pain with additional patient benefits. And they indicated that the reference study conducted by Simpson et al. Is inadequate to support this claim because it was an open-label, single-arm trial with no control group. They were not aware of substantial evidence or substantial clinical experience to support this claim.
Okay, and so they found, in essence, the study was insufficient or inadequate to support that claim.
Yes, sir.
All right. Now, you say file card. What do you mean?
Yeah, my understanding is that's the piece that was provided to healthcare providers by the sales representative.
And the file card in this case is S2524. Or the promotional material is that. Do we have the actual file card? Anyway, this is the material they're referencing, correct?
Yes, sir.
$25.24. The file card. If you'll look at that document 2524,
Give me.
what is it we're talking about? Is it in that piece of material?
No, they specifically go on to say that the claim, 1,360 loaves and counting, work uninterrupted, life uninterrupted, game uninterrupted, and chronic pain relief that supports functionality, helps patients think about their pain, think less about their pain, improvements in physical and social functioning. These claims are misleading because they imply that patients will experience improved social or physical functioning or improved work productivity when using Duragesic. They are not aware of substantial evidence or substantial clinical experience to support these claims.
So we're talking about functionality here.
Yes, sir.
correct? And is that what the Simpson study discussed?
Yes, sir, it is.
The portion of the Simpson study cited in the file card, quote, demonstrated effectiveness in chronic low back pain with additional patient benefits. Did I read that correctly?
Yes, sir, that's on the second page.
Is that what Simpson studied in its patient population referenced in its study?
Yes, sir, it did.
Okay, what did the file card say next? 86% of, it's again on page 2.
That on page 4 and 5, the file card includes the claims 86% of patients experienced overall benefit in a clinical study based on pain control, disability, and activities of daily living, quality of sleep. All patients who experienced overall benefit from Duragesic would recommend it to others with chronic low back pain, significantly reduced nighttime awakenings, and significant improvement in disability scores as measured by the OSWESTRY, OSWESTRY Disability Questionnaire and Pain Disability Index.
And when you read those study results to us earlier in the day, while I doubt anybody will remember the percentage, they'll never forget the OSWESTRY. OSWESTRY, yes, we'll forget how to pronounce it, but we will not forget it exists. OSWESTRY scale.
Yes, sir.
And did that finding mirror the finding in the Simpson study?
Yes, sir.
Are these claims that we just discussed in the work uninterrupted material consistent with what you saw in the Simpson study?
Yes, sir, they are.
We talked a little bit about open label studies before.
Yes.
If you look at the warning letter, did it discuss the fact this was an open label study?
Yes, sir.
And what did it say about the use of an open label study to support the claim?
That they didn't believe that an open label study could sufficiently support the rigor needed to make these claims.
Now, is the Milligan study discussed on page 6 and 7?
Yes, sir.
Do you have the Milligan study there in front of you, or should I give you a copy of that as well?
If you just want me to read off, that's fine.
You read it off, whichever one is easier.
Thank you.
And if you look at page 3, is that where the Milligan study is discussed?
Yes, sir.
Does the file card disclose that the Milligan was an open label study?
Yes, sir.
Does it disclose that it was a 12-month prospective study?
Yes, sir.
Does it disclose that it observed improvements in patients' physical functioning summary scores as you described to the court earlier today?
Yes, sir.
And did it observe that there were improvements in patients' social functioning as you told the court earlier today?
Well, the letter from the FDA reports on what we included in the promotional piece.
And did that misrepresent the observations from that study?
It did not misrepresent the observations in the study.
Did you and Janssen believe that this study provided evidence of real-world effectiveness data?
Yes, sir, and that's why it was published.
And having received the warning letter, which you have there in front of you, what did you do?
We responded to the FDA with additional information relative to their concerns, but ultimately we withdrew the promotional piece and issued a Dear Doctor letter to all of the physicians who might have received the promotional piece, and Dear Doctor letters through organizations to which many of these physicians might have been members.
Did the warning letter also discuss the Allen study, which we mentioned and went through earlier today?
Yes, sir.
Is that reflected in the third paragraph of the letter?
Yes, sir.
Does this letter tell you how that study was used in the file card?
You're looking at,
The FDA warning letter again.
yes,
It's the part where it refers to...
yes, I see it, yes.
There you go. Okay.
Yes, yes, again, we're looking at the claims, improved patient outcomes, open label crossover comparison study, significant improvement in physical functioning, significant improvement in social functioning. And the FDA goes on to say, to support these claims, the file card cites the study conducted by Allen et al., an open label study, cannot minimize bias in the reporting of subjective response in the SF-36, which was the tool that we used in the study.
And did the file card disclose when it was sent to the FDA that this study was an open label crossover comparison study?
Yes, sir. I believe we would have provided all the references that were used in the promotional piece.
Do you know what claims were being presented here that related to the Allen study?
Improved patient outcomes.
And do you believe the file card accurately represented the data from that study?
I believe the study does show improved patient outcomes.
You mentioned we sent a letter to the FDA after receiving the warning letter, which is in front of you, and that, I believe, is J861. Yeah.
Thank you.
Please take your time and look through there and tell Judge Botman what 861 is if he's forgotten since it was introduced some time ago.
Yes, this is our response to the FDA, specifically with respect to the warning letter.
Now, what did you tell the FDA, you being Janssen, what did you tell the FDA with response to the studies we have discussed, Allen and Milligan?
Give me a moment to review it.
Sure.
We indicated that, for one thing, the drug is approved for treating chronic pain and didn't specify the types of pain, and we saw low back pain as one specific area of chronic pain that might be treated with Duragesic. We cited the data around the SF-36, and we cited additional data that had been collected in support of a claim for low back pain.
Now, I want to go through those, but as specific to the Allen and Milligan studies, physical and social outcomes from clinical experience, if you look at page 6 of the response, very bottom. Is that what you're referencing?
Yes, sir.
And can you tell the court what you told the FDA in this response letter?
Yes. We understood the FDA's concern about the lack of controlled clinical data to lack support for the claims. We were making the point that this study was set up as a real-world effectiveness study. It was set up to answer the question of, if I put a patient on this drug today, what might I expect to see over the course of the next month, 3 months, 6 months, 1 year's time? It's an effectiveness study rather than an efficacy study. It's answering a different question.
And if we go back to the paragraph above that, is this the paragraph in response to the chronic back pain study that you discussed earlier with Judge Bob?
Yes, sir.
All right. Now, what was Janssen trying to convey to the FDA in this letter?
That the information we were providing, that efficacy had been already determined. The drug was approved based on efficacy and safety data, and that the benefits outweigh the risks. We heard from the healthcare community that they wanted to have data in specific chronic pain conditions, and they wanted data on long-term effectiveness. Not controlled data, but what happens when I'm putting a patient on the drug over a long period of time? What's the likelihood that they're going to tolerate the drug for 3, 6, 12 months? How long will they continue to maintain the benefit of the drug? And that's what these effectiveness trials were intended to provide.
Was your response limited to your comments on the 3 studies that we've discussed?
No, sir. We brought in additional studies.
And if you'll flick just over to the next page, page 7. You there?
Yes, sir.
All right. I see Fen USA 71, Fen USA 72, and tell the court what you're trying to convey here.
That in addition to the data that was submitted under Milligan, Allen, and Simpson, we had additional data that were generated from clinical trials in the United States. These were controlled clinical trials in that patients were randomized to receive either Duragesic or, in one study, a controlled release form of oxycodone. In the second study, a short-acting oxycodone. In one study, we looked at chronic non-malignant pain. In the second study, again, we looked specifically at low back pain.
And you are familiar with these post-approval studies?
Yes, sir.
The previous studies we've discussed, Allen, Milligan, and Simpson, did they contain the peer-reviewed publication studies that you told Judge Bachman about earlier today? I mean, that's what we're talking about, right?
Yes, sir.
The one published at Baylor and in the British Medical Journal and the American Society of Pain.
Yes, sir.
Now, what did you, by the way, those studies, were they funded by Janssen?
Which studies are
The
you?
ones we talked about earlier today?
Yes.
Is that uncommon?
No, sir. That would be typical for a clinical trial in which we're trying to gather additional data to answer a specific question. That's the objective of the study, and we would set such studies up in multiple centers and multiple centers that are seeing the specific patient population that we're interested in, but they also have the expertise to do a clinical trial. There's a lot that's involved with that in terms of seeing the patient and then filling out the case record forms in a highly standardized way that would hold up to an audit.
And is the funding revealed at the ends or in the middle or somewhere in the article?
Usually it would be, yes.
Okay. And was the FDA saying the studies were not good because Janssen funded them?
No, sir.
Now, you were talking about Fen USA 71, 72, and finally Fen out 405. You're going to have to tell me what these studies are and why we should consider them.
Yes, we spoke about Fen 71 and 72 as controlled trials, crossover trials, in which, similar to, I believe, the Allen study, patients got either Duragesic or an oxycodone preparation during the first period, and after the first period, they would cross over to receive the alternative therapy. And we assessed them for quality of life measures, efficacy, and safety. Then out 45, the out indicates this is an outcomes research study, and this was an observational, usual care prospective trial in 358 patients with chronic low back pain. Specifically for an outcome study, they were looking at measures of functionality.
And did you believe these additional studies provided support for the first several studies that you mentioned, Allegan, Milligan, and Simpson?
Yes, sir.
Okay. Now, the FDA letter also references a safety claim, abuse claim, correct?
Yes, sir.
And tell the court about that, or remind the court about it, because you've been testimony about it already.
We used Dawn data on mentions of abuse, and they took issue with the mentions of the Dawn data.
Okay, now explain to us again what Dawn
This is the Drug Awareness Warning Network. These are visits to emergency departments across the United States in which they collect data on the reference drug that led to the admission to the emergency room.
And specifically, if we look at page 2 of the warning letter, the FDA says, first, we are not aware of evidence or substantial clinical experience to support this comparative claim. What is this comparative claim?
That Duragesic is less abused than other opioid drugs.
The Dawn data cannot provide the basis for a valid comparison among these products. What are these products?
The Dawn data presents information on many products, but specific to the opioid products, on all of the opioid products that might be mentioned during a visit to the emergency room.
Did this letter say that, in fact, Duragesic was not less abused?
No, it did not.
Did the FDA say Dawn data cannot be provided to the medical community?
Not in a promotional piece, no.
Did the FDA tell you that Dawn data was unreliable?
No, sir, it did not. The FDA itself uses Dawn data.
The FDA itself uses Dawn?
Yes, sir.
Now, the timing here is 2004, correct?
Yes, sir.
And did Janssen get additional data regarding abuse rates that it had set forth in its initial position?
Could you clarify the question?
Well, you've talked a lot about surveillance that has gone right up to today, correct?
Yes, sir.
Does that data support the fact that, in fact, Duragesic has a lower abuse rate?
Yes, sir. So relative to the Dawn data mentions, by this point we had collected additional surveillance data from the other systems that we had in place to assess abuse, misuse, diversion of Duragesic, and consistently we saw low rates of abuse for fentanyl, for Duragesic, relative to the other opioid compounds.
And did you also raise this with the FDA in your response letter, which is sitting there in front of you, marked J861?
Yes, sir, we did.
Can you point to the court where you did that?
Yes. If you start on page 1, it's the section beginning with low abuse potential.
Give us just a second, Doctor, and we'll get there so you can show Judge Botman what you're referencing. Thank you, James. Take your time and just tell us what you're trying to tell the FDA in your response to its letter.
Well, we agreed with the FDA that the Dawn database is not a clinical trial database. These are mentions in the emergency department visits, but that this is nonetheless a valid and well-recognized and respected source of information about substance abuse. These are mentions that come from intentional abuse of the drug, not accidental ingestions or substances with no intent of abuse, and that the Dawn mentions are specifically for products that are either Schedule II or Schedule III products with the recognized significant potential for abuse. We also provided additional sources of information to support a lower incidence of abuse with Duragesic.
And if you can turn to the next page, Dr. Moskovitz, does this contain the additional data or studies you provided the FDA in support of that claim?
Yes, sir. This was a publication by Zacny in 2003 in which he analyzed narcotic analgesic abuse relative to legitimate availability across an 8-year period where he looked at fentanyl, morphine, oxycodone, hydrocodone, and hydromorphone. And all 5 drugs experienced an increase in emergency department mentions and drug availability, but went on, because one of the issues with the FDA was that we didn't cite a rate, so we had no denominator. So he goes on to say that although fentanyl and morphine have shown increases from 1995 to 2001 in the ratio of illicit use to licit use, non-pharmaceutical use to pharmaceutical use, both the ED mentions and the number of prescriptions dispensed are several orders of magnitude lower for hydrocodone and oxycodone. The ratio of illicit use to licit use has increased for oxycodone and morphine, but remained relatively stable for fentanyl and hydrocodone. So the FDA's concern was that we cited the mentions without citing a denominator, without citing the rate. And they were concerned because there were simply fewer prescriptions written for Duragesic. Here we were able to provide a rate using the number of prescriptions for Duragesic and the other compounds.
If we go down just a little bit further, I think there's a figure.
Yes, sir.
You're going to have to explain this very basically to get me to understand, because I don't know a denominator from deep center field. So if you will tell me what this chart shows as it relates to what you're trying to tell us.
Yes, sir. Well, the x-axis is simply the time period over which this is being reported, 1995 to 2001. The y-axis is the ratio. So now we're looking at the emergency department mentions divided by the number of prescriptions. So this would normalize the data for a drug that has a high number of prescriptions and a high number of mentions, or a low number of mentions simply because there's not much drug out there. There are few prescriptions written. And if you look across this period of time, fentanyl is always the lowest line in this period.
When was the Zacny article that you're referencing published?
In 2003.
And did Zacny have the Dawn data that has been discussed from 1995 to 2001?
Yes, sir.
And what is the objective of the Zacny study as it relates to that data?
They're assessing the Dawn data, the emergency department visits relative to abuse, but normalizing the data relative to the number of prescriptions of that product.
Are they providing the denominator?
Yes, sir, they are.
Okay. And does it then compare those rates with, say, OxyContin?
Yes, it compares the rates with oxycodone, well, not OxyContin, let's be clear here.
Oxycodone.
This is relative to oxycodone, hydrocodone, and morphine.
Thank you for that correction, doctor. Was there another study that you gave to the FDA.
Yes, sir.
And just go on and tell me what, if anything, those studies added to our conversation.
That was a report by Dr. Mironer, Mironer, in 2000, in which he conducted a 3-year retrospective medical records data. He looked back on a database over a 3-year period from a large pain clinic to study the relative misuse potential of 9 opioids, where he described the endpoint, what was defined as misuse of opioids. So that would include such things as seeking multiple prescribers, urine toxicology, and others. They looked at the medical records of 139 patients who met the criteria of documented misuse, and they reviewed the records for these 139 patients to determine what opioids they used. They compared that with information obtained from another 200 randomly selected charts of patients currently receiving opioid therapy, and looked at the ratio of the frequency of misuse to the frequency of active proper use. So they're taking these individuals whom they identified as having had markers of misuse and what they were taking, and compared them with another 200 individuals who had no evidence of misuse to look at a ratio for the specific drugs.
And was there another article then cited or discussed in the response to the FDA?
Well, to begin with, if you look at the Mironer data in the first table, they found that the rate of misuse, that is comparing individuals from this database who had markers of misuse, and then they looked at what they were misusing relative to a population treated with opioids that was not misusing the opioids. They found that the misuse potential for fentanyl, in this case it is Duragesic because it's labeled the fentanyl transdermal system, was lower than all of the other opioids except for methadone.
Now, Doctor, is there another study there, Janssen?
Yes, sir.
We've heard Janssen's name mentioned earlier in this trial, but I want to ask you specifically, the Janssen article is written in what year?
In 2000?
Have you reviewed that article?
Yes, sir.
And does it provide data earlier than the Zacny article, which was discussed as the first article you spoke to the court about a few moments ago?
Yes, sir.
Is it fair to say that between the time of this Janssen article and the time of the Zacny study that you referenced, that the Dawn data had been updated?
Yes, sir. There were additional years of data in the Dawn database at that time.
And was that data reflected in the Zacny article that you showed us, which added the denominator or individualized those numbers?
Yes, sir.
And can you explain, hopefully for the last time, why that's important?
Well, the FDA in their warning letter specifically cited that the Dawn data simply mentions and don't normalize the data relative to the number of prescriptions. And the Zacny data did exactly that. They used a denominator of the number of mentions relative to the prescriptions written.
Thank you, Doctor. If I say ARCOS, what does that mean to you?
That's another database that's used that looks at use and misuse.
Is that a government database, do you know?
Yes, sir, it is.
And what does that database, who keeps that database?
I'm not certain.
Is it, if I said the DEA, would that make sense?
It would make sense, but I'd have to confirm that, yes.
Do you know what ARCOS tracks?
They look at issues of abuse relative to total mentions. They have a database of abuse and diversion, use and abuse of opioids over a period of time.
Yeah, I think actually it follows the flow of DEA-controlled substances, doesn't it?
Yes, sir.
As opposed to how I mischaracterized it before. So does this compare to using DAWN data, using a denominator, the ARCO study? It's not up there. I mean, I'm talking in general.
Right, yes. Well, here they're simply looking at a comparison of what happened in terms of medical use, the uses of the product relative to the abuse mentions over this period of time, 1990 to 1996.
Okay, what does that add to our discussion here as it relates to the Janssen article?
Well, it helps to provide a bit more of a complete picture where, specifically here, over this period, 1990 to 1996, there are a number of compounds where the medical use went up, in some cases substantially. And if you look at the rates of abuse, in some cases, let's take oxycodone. Over the period of time from 1990 to 1996, the use of oxycodone rose approximately 23%, and the rates of abuse actually decreased over that period of time. The rates of morphine, rates of abuse increased. But if you look at fentanyl was released to the market in the early 90s. Duragesic was. The medical use rose substantially, over 1,000%, and yet the rates of abuse that went down over that period of time.
So by combining this drug abuse warning network, or DAWN, with the automation of reports and consolidated orders system, or ARCOS, what can you learn?
Well, this again gives you a denominator. So we're able to look at the increase in use of the product, or the change in use of the products relative to the mentions.
And there is a table there which you have already marked. Does that support the position regarding fentanyl which you had taken in the file?
Yes, sir, it provides support.
Just as the Zacny study did that you discussed before.
Yes, sir.
Did both the Zacny and Janssen study find that fentanyl abuse was low when compared to other products such as oxycodone?
Yes, sir.
Now, we've already discussed the Mariner study, and you've already talked about the table. Was that study consistent with that finding?
Yes, sir.
If you look at page 6, there is a reference to one other manuscript.
Yes, that was a manuscript by I believe it's Mr. Coleman.
Yes, and the court's heard Mr. Coleman and Janssen mentioned before. Tell me what the significance, if any, of this manuscript was.
Well, here too, he's looking at reports that assess risks of abuse of the various opioid compounds. He reviewed federal databases and surveys of police departments to determine specifically whether transdermal fentanyl, Duragesic, was the subject to widespread abuse. He noted that in 8 of the last 10 years, there actually weren't enough mentions in DAWN data to be included in the list of abused drugs. If you were looking at medical examiners, fentanyl at this time was mentioned in a small fraction of drug-related deaths. And he goes on to say that for subjects admitted to federally funded drug treatment programs, keep in mind this is very similar to the surveillance data that we would later be putting into place. So admissions to a federally funded drug treatment program, there were no mentions of admissions for treatment due to the use of transdermal fentanyl for Duragesic. He goes on to look at other databases, STRIDE2, NIFLIS, the National Forensic Laboratory database, where he points out that there are rare mentions of fentanyl. He looked at police departments who responded to a survey. 33 of 38 police departments reported no criminal activity relative to Duragesic. And the author concluded that the transdermal formulation of fentanyl, that is Duragesic, was not widely sought by drug abusers nor widely diverted or sold by drug traffickers in the U.S. in the 10 years since its introduction. Again, providing support to the claims made in the promotional piece.
You know Coleman, John Coleman?
Yes, I do.
His name has come up before. He's somebody that worked with Janssen on projects?
Yes, sir.
Okay. Let me hand you what has been marked, if I might, J2643, and ask you if this is the study that was discussed there. Report, manuscript that is mentioned there.
Yes, sir.
And if we can, I would offer J2643 into the evidence.
No objection.
J 2643 will be admitted into the evidence.
If you look at pages 2 and 3, you'll see methods described.
Yes, sir.
And Dr. Moskovitz, can you just tell the court what Mr. Coleman's manuscripts looked at?
They looked at a number of surveillance points that were collected through Dawn databases,
Okay,
through,
we've heard of Dawn.
right?
What is TEDS?
Well, the treatment episode data set, which collects information on approximately 1.6 million substance abuse treatment admissions reported annually by states receiving federal assistance for substance abuse treatment.
And then we talk a little bit about federal law enforcement databases. You mentioned FLF.
Well, we didn't use an acronym for this one.
Right.
These are arrests.
There are some listed there. STRIDE2, STRIDE, we have not talked about before. Can you tell the court what those are?
Correct. These are databases on arrests relative to crimes associated with, which they obtained forensic data from forensic reports on criminal cases where there may have been diversion of an opioid, and specifically they were seeking information on transdermal fentanyl, which is Duragesic.
If we go to the next page, I think you'll see that National Forensic Laboratory Information System we discussed before.
Yes, sir.
And then there's something called the Police Department Survey. Can you tell the court what that is?
Yes, they conducted a survey of local police agencies over which they sent letters to 51 police departments throughout the United States, representing some of the largest population centers in the United States. And they requested information about reports or any reference of incidents in which the police department encountered unlawful activity involving fentanyl patches, which at this time was only Duragesic.
Now, if we look at page 8, there is a table. What can we learn from this?
Well, this information goes back to the DAWN database. These are mentions in emergency department visits. And we're looking here at the number of mentions. And you're seeing here, and specifically, this is drug abuse related deaths that are reported in the DAWN database. And relative to the number of mentions, and the number of mentions for fentanyl are low, the percent of total deaths was among the lowest of all the drugs that they surveyed.
Table 2 references the NF
National Forensic Laboratory.
You got it.
Yep, these are forensic laboratories in which they assess the drug that was involved in a seizure.
And where is fentanyl on that list?
The fourth citation from the bottom.
Now I want you to turn to page 10. What do you have here?
It's simply a listing of the criminal activity in which a transdermal fentanyl patch was isolated, and the police departments remember they sent out a survey to these. Thank you. Okay, now let's go back to the listing. They sent out a survey to the police departments, and these are the police departments that reported back, but reported that there was no criminal activity related to transdermal fentanyl, to Duragesic.
And what's the second from the bottom?
That was the Tulsa Police Department in Oklahoma.
So reviewing all these different data sources, what did Mr. Coleman conclude about the rate of abuse of Duragesic?
That relative to other opioids, the rate of abuse of fentanyl was low.
At the time of this letter we've discussed, did Janssen have available to it the radar's data which you discussed with Judge Bachman earlier today?
No, sir, we did not.
And when did it start receiving that information?
In the mid-2000s, I believe 2006.
All right. Now, even if the FDA disagreed with Janssen's use of DAWN data in the original file card, did the radar's data ultimately show that the abuse of fentanyl was consistently lower than other Schedule II opioids?
Yes, sir. When we received the radar's data in 2006, we also got data for the prior years from 2000 or 2001 through 2006, and confirmed that with the information that was collected in the radar system, the rates of abuse of fentanyl was consistently among the lowest of the opioids.
Thank you, Doctor. Did this surprise you that fentanyl was less abused than other opioid drugs in the radar's data ultimately?
No. Specific to the Duragesic system, recall that the decision to develop the transdermal patch in the specific formulation that it was developed was done so because we believed that it would be less attractive for abuse because it had an extended period of release over 72 hours. It was in a formulation where you could not get a discrete dose of the drug, where if you tried to withdraw it from the reservoir, For IV use, it would be gelatinous. It would be very difficult to use or to purify for injection. And finally, because what we saw in internet monitoring, it was considered to be a drug that had high risks of death associated with it if it were to be misused.
Thank you very much, Dr. Moskovitz. We need to cover another thing here that came up in the state's case. Do you know a fellow named Vincent Brett?
Yes, sir, I do.
Tell me who Mr. Brett is.
Vincent Brett was one of the individuals in our medical services group, and he would have been responsible overall for the types of activities that were conducted through the medical services group. That would include such things as reviewing literature, providing literature to healthcare providers if there was an inquiry, if they wanted more information about a specific topic on one of our products. But he would also have been reviewing the data that might be used as a supporting document for a promotional piece, for promotional review, or a document that might be used in any external educational piece.
In that capacity, did he have clinical experience or not?
I believe he was a PharmD.
Okay. And can you bring up S2510, Janice? This email was shown earlier in the trial, and I want to ask you some questions about it. Have you seen this before?
Yes, sir, I have. Do you have a copy for me?
Of course.
Thank you.
This is in the evidence on
Thank you.
You got that in front of you now?
Yes, sir, I do.
Tell us what S2510 is.
It's an email from Vincent Brett, who is in our medical services group, to nutrx@comcast.net. This was, I believe, an external group that was putting together a slide deck that might be used to educate around Duragesic.
Okay, so an outside group putting together a slide deck for purposes of giving some information about Duragesic.
Yes, sir.
Okay.
And this was, the email was sent late in 2007.
How many years after that is, we've been talking about a warning letter before, remember all our
That's
discussion
correct.
about
The warning letter
When was that?
The warning letter was 2004. This occurs in 2007.
Okay, about 3 years later.
Yes, sir.
So what do we see in this email chain?
Well, he's describing to the group that's responsible for putting together this potential deck, educational deck, slide deck around Duragesic, some of the problems with the use of the Simpson, Milligan, and Allen data.
Okay, and it's
Problems that
talking-
we've learned about from the 2004 letter.
All right, and this refers to a CRC meeting? Is there some reference to a CRC meeting somewhere in this?
If that would be it would be similar to promotional review.
I think they said it's basically the same.
Yes, there were at times we called it a copy review. At times we called it promotional review.
And I think that's already been in the evidence. So what happens next?
Well, the slide deck was never used.
Okay. Now, this slide deck you indicated was created out of house, not in-house.
That's correct.
And you see Mr. Brett's comments on it.
Yes, sir.
And what's the basis of that as you read it? And free to look at the copy in front of you or call up anything you want on the board.
Well, fundamentally, we knew from the 2004 warning letter that the FDA did not consider the studies to have substantial evidence for efficacy or the claims that we were trying to make. And so that was what James Burrows and the regulatory group and Vincent Brett were bringing out.
You indicated that the 2004 letter was circulated among people at Janssen and Medical Affairs.
Yes, sir.
And these comments that are made 3 years after, but Mr. Brett characterizes the FDA as having rejected the studies.
Yes, sir.
Do you agree with that characterization?
Well, they rejected the studies with respect to not having provided the level of rigor that they would require for a promotional piece.
And did Mr. Brett, in his general comments, indicate that the studies could not be used in the slide deck in question?
Well, he had some comments on how to appropriately frame the studies if they were to be used in the slide deck.
In fact, did he comment specifically on the Milligan study?
Yes, sir.
And what did he say the Milligan study could or could not be used?
Well, I don't have his specific comments on the Milligan study, but he thought that we should be including information on the limitations of the study.
I've handed you another document which is in evidence, 2511, which may give you the answers you're looking for. Please take a moment to review.
And he indicated, specific to the Milligan study, for one thing, that we should consider deleting it from the slide deck, but if we chose to keep it in the slide deck, consider adding at least speaker notes to explain the design, the primary efficacy and secondary outcomes assessment, the primary efficacy endpoint, and the secondary outcome assessments, the baseline demographics, what was the population that was enrolled to the study, the disposition of the patients from the time they were enrolled, what happened to the study patients, and there's a way to categorize from the patient who enrolls into the study to the assessments and what happens if they fall off the study and who's analyzed for the study. So he laid out a way that we might use these data more appropriately.
And if you'll look at page 5, is all of that comment contained in this document?
Yes, sir, it is.
Did the file card that we discussed earlier use anything that Mr. Brett criticized or was saying was weak in these studies?
No, except that it presented the results of the study.
And looking at page 5, can you go through and just tell us whether Mr. Brett was referring to the study as an efficacy study?
Well, he pointed out that some of the terms, such as global efficacy, were unclear, that would need to be explained. It wasn't the standard efficacy that you would expect from a study of pain where you might look at a visual analog scale.
Okay, and was there any other comment that he had regarding that you need to talk to the court about?
No, I mean, he thought that overall the study shouldn't be included in the slide deck, that there were limitations, but if we were going to include the study in the slide deck, we would need to provide the limitations of the study and some of the definitions around the patient population that was entered to the study and the explanation of the endpoints more clearly.
You have all of these documents now in front of you, Dr. 2521 and 2511, that are the comments Mr. Brett made about the studies. Do you agree with his comments?
I certainly agree that we could present the data in a more comprehensive way. There was no question at the time that we shouldn't be using it as a promotional piece. That was our understanding from the 2004 warning letter. There were better ways to represent the data in an educational manner if we were developing a slide deck, and I think that Vince Brett helped the individuals who might have created the slide deck to understand that. Ultimately, we did not develop the slide deck. We did not use the data from those studies.
So the bottom line is you had a discussion about it and you didn't use the studies for the slide deck that Mr. Brett is discussing.
That's correct.
Anything else that you need to tell the court about Mr. Brett's criticism of the studies as it relates to the potential use in the slide deck that was being recommended by this outside group?
No, sir.
Now, there's another email I want to ask you about. S1769. This is an email chain. Do you recognize this?
Yes, sir, I do.
And it is admitted into evidence. Can you please tell the court what we're looking at here?
Yes, sir. Do you have a copy of the...
Ma'am.
Thank you.
You're in this email chain?
Yes, sir.
Okay.
This was, well, the middle of it is my reply to Julia Donnelly, whom I don't recall, but Uta Richards was a colleague of mine, a physician in Germany who had responsibility overseas for Duragesic. And she asked me to review a slide deck that related to pain management and to Duragesic, and I made comments to her on my review of the slide deck.
So we have the 2007 emails from Mr. Brett regarding a slide deck, candidly discussing his views, and you indicate that the studies indicated or talked about were not used in any slide deck. Tell me what the upshot of this email is.
Well, I pointed a couple of things to her, but I think most specifically I spoke about the DAWN data, that we don't use the DAWN data to conclude low addiction potential, not by itself. We had other data at that time.
I want to ask you about that. We, never all capitalized, use DAWN data to conclude low addiction potential. Now, previously we've been talking about low abuse potential. And what again does DAWN stand for?
Drug Abuse Warning Network.
Is there a difference between abuse and addiction?
Yes, sir.
And what are you trying to say here?
I believe that one of the slides suggested that the DAWN data in some way represented low risk of addiction. and that is not what the Dawn data presents. I made it very clear that we do not use the Dawn data as any representation to indicate a low addiction potential. I went on to say that we know that fentanyl is a highly addictive opioid, and there should be no data presented to suggest otherwise.
Is this the same as evaluating Dawn data for low abuse potential?
No, sir.
Please tell the court why that is.
Well, addiction and abuse are two separate issues. Addiction is relative to the specific compound. We're dealing with fentanyl, misused, not used properly, not used in the context of a prescription, not used in the context of a patient who is being monitored and educated by his or her physician. By virtue of it being a Schedule II product, we know that it has a high potential for the risk of addiction.
And are these comments in the emails we've just looked at, the 2007 emails that we talked about previously about the slide deck for these studies, and this one about the Dawn data and addiction, the kind of candid conversation you have inside at Janssen when you want to discuss these subjects?
Yes, we always recognize that used improperly, used outside of the context of a physician, a proper physician-patient context, that by virtue of having fentanyl, there was a high risk of abuse, misuse, diversion, and addiction.
And the fact that Duragesic is classified as a Schedule II drug indicates that it has the potential for addiction?
Yes, sir.
Which is why you say never use Dawn data to say that it does not.
Well, the Dawn data doesn't speak of addiction.
Exactly.
That's...
Okay, anything more you need to comment on about those two sets of email chains that were discussed earlier in the case?
No, only that I also pointed out that the contraindication in the United States for using Duragesic in an opioid-naive patient, a patient who had not been previously exposed to an opioid.
That's something you talked to us about before today, correct?
Yes, sir.
All right. Anything else we need to look at in terms of those two emails before we move on?
No, sir.
All right. Doctor, I want to talk to you for the remaining time we have today and see if we can get on another 10 or 15 minutes or however long the court wishes to go.
I think till about 5 o'clock will be fine.
And discuss Nucynta.
Yes, sir.
What is Nucynta?
Nucynta is a formulation of tapentadol. Tapentadol is the active molecule both in the immediate release and the extended release.
Previously today, early on, if you can remember that far back and as many words back as we've had, you talked about the unique delivery system for Duragesic, the
Yes, sir.
transdermal delivery system.
Yes, sir.
Is tapentadol a unique opioid molecule?
It's a unique molecule that goes beyond just being an opioid. Yes, sir.
You tell us, please, what makes it unique?
Yes, sir. With all of the opioid compounds we've been talking about today, we're speaking about compounds that have their activity solely through the mu receptor. They block the mu receptor, and therefore they have some pain relief. Tapentadol was a new molecule that had more than one mechanism of action. It had what we called a dual mechanism of action. You could obtain the activity, the pain-relieving activities, through both the mu receptor, which is why we called it an opioid, So pain relieving through the mu receptor, but it also had a second mechanism of action, which was norepinephrine reuptake inhibition. I know that's a mouthful, but there was a recognized second route through which the compound provided pain relief.
As a simpleton in drug matters, I've had it described that it works in the brain and at the site of the pain. Is that some way to look at it, or is that just too simple?
Well, that's certainly one way to look at it. I think for purposes of explaining it, when you transmit pain, it gets transmitted through the nervous system. The neurons in the nervous system don't actually touch each other. There is a space between the neurons. And there are various ways in which they talk to each other to do what they need to do, whether that's move a muscle or relay pain signals. With tapentadol, we were able to affect two mechanisms of action. One in which we blocked the receptor, the mu opioid receptor. That provided some of the pain relief. But one of the chemicals that these two neurons use to talk to each other is called norepinephrine. A neuron would release norepinephrine, and by uptaking norepinephrine in the downstream neuron, they talk to each other. Tapentadol being a norepinephrine reuptake inhibitor. The neuron releases norepinephrine, but if there's excess norepinephrine, it will take it back up. Tapentadol blocks this uptake, so there's more norepinephrine in this space between the two neurons. By having more norepinephrine there, it actually modulates the recognition of pain. It's recognized with a number of other compounds. It's used in antidepressants. It's not only used as a pain medication. My point is that we had a new molecule that didn't depend solely on the mu opioid receptor for modulating pain. It used the mu opioid receptor, and it had this second mechanism of action, which was known as norepinephrine reuptake inhibition, also to modulate pain.
Specific questions. How did this dual mechanism of action relate to a patient's ability to tolerate the drug?
We thought of this as a wonderful advance in pain treatment because there are known side effects with using the mu opioid receptor. Specifically, many patients who take an opioid compound will experience constipation, nausea, vomiting, pruritus, which is itching. By having a compound that didn't rely solely on the use of the mu receptor, but that had this second mechanism of action, we believed that the clinical trials would show that you could get the same level of pain relief that you would get with a pure mu opioid agonist, blocking the mu opioid receptor, but because part of the pain relief was not dependent on the mu receptor, that you would have a better tolerability profile. You would have fewer adverse events, specifically the adverse events that were most closely associated with an opioid: gastrointestinal, constipation, nausea, vomiting, and pruritus, the itching that were typically seen with an opioid.
Was there any thought about how this might affect the euphoria some patients feel taking an opioid?
Yes, because here too, if you're not dependent solely on the mu receptor, that there might be a lessened euphoric effect of the compound.
How was tapentadol developed?
It was developed by Grunenthal, and they recognized that this was a compound that had these two mechanisms of action.
Did Janssen market both a short-acting and long-acting or extended release version of tapentadol?
Yes, sir, we did.
And the court's heard about that, I think referenced in Nucynta IR and ER?
Yes, sir.
All right. Now, you've told us before that Nucynta IR was released in 2009.
Yes, sir.
There were other opioids available at that time, correct?
Yes, sir.
The question has been asked in this case. Why did Janssen choose to release an opioid in 2009? Can you answer that question as it relates to Nucynta, please?
Yes, sir. I did hear the testimony about why would we release a new opioid in 2009. We believed we had a better compound. We believed that based upon the dual mechanism of action, we could see equal efficacy with much better tolerability, fewer side effects that could lead to not just better efficacy, but a better fall off if patients couldn't tolerate the drug.
And did the data support that belief?
Yes, sir, they did.
How?
In fact, in the studies that we did, we showed that in the controlled clinical trials, especially the clinical trials where we had a comparator opioid, and the comparator opioid was usually oxycodone, we in fact showed that the drug had efficacy, reduction in pain, equal to oxycodone. But then when you looked at the adverse event profile, the incidence, the number of the frequency with which you saw constipation, nausea, vomiting, and pruritus were approximately half what you saw with oxycodone. This also played into the number of patients in the clinical trials who had to discontinue from the trial, not because they weren't getting pain relief, but because they were having adverse effects.
Was Janssen's decision to market Nucynta driven by a goal to expand the pain management market?
No, it was driven by the belief that we were bringing a better compound to the market.
We already had Duragesic on the market, correct? With
Yes,
the
sir.
unique transdermal delivery system. Why not just focus on that? Why introduce Nucynta with Duragesic on the market?
Well, we already spoke about how fentanyl, Duragesic, is a pure mu opioid agonist, and therefore would have the tolerability of a pure mu opioid agonist. We were bringing to market both an immediate release formulation of a new compound and an extended release formulation of a new compound.
Thank you very much, Dr. Muskovitz. This would
Well,
be a good... Do you have something, anything
yes,
else you
I-
want to say? Now's the time to say it.
Yes, I do want to add that for the extended release, we brought this drug to market. This was the first extended release compound brought to market in which from the moment it was introduced to the market, it was brought in a tamper-resistant formulation. The formulation of the extended release was in a form that made it difficult to chew, to snort, to get the active ingredient for injection. And this was although some of the other opioids later switched to a tamper-resistant formulation, this was the first new compound that was introduced to the market from the outset in a tamper-resistant formulation.
Thank you for that observation. This would be a good time. You indicated you wanted to break, Judge, at 5.
I think we got another 45 minutes. No, I'm just kidding.
You're probably going to start at 7:30.
We will we'll call it a day today. Thank you, Dr. Moskowitz,
Thank
Mr.
you.
Ottaway. We'll begin again tomorrow morning at 8:30.
Thank you, sir.
All right. Thank you very much.